The genomic landscape of acute lymphoblastic leukemia is coming to the stage now where the vast majority of patients can be assigned to probably one of about 20 to maybe 25 genetic subtypes across both B and T lineage ALL. So in terms of its impact on patient management, this is a very exciting time. So it's already known that many of these genetic subtypes are associated with either a good response or a poor response to standard chemotherapy. And the vast majority of clinical trials across the world, particularly in developed nations, will be using genetics in order to determine what therapy each patient receives. There is a relatively small number of patients such as those with BCR-ABL fusion or ABL class fusions that will get targeted therapy. But as we learn more about the functional consequence of these genomic alterations in acute lymphoblastic leukemia, the potential for the number of targeted therapies to come to the fore and get into frontline therapy will increase massively. Initially, over the next couple of years, what you will find is we will find that we will be able to assign patients much more accurately to either a good risk, intermediate risk, or high risk group based on standard chemotherapy. And this will be done not by kind of default, which is currently the situation with many patients where we don't identify the key genetic lesion, but will be done positively. And this, I think, will improve risk prediction for all patients with pediatric ALL and indeed adult ALL, where the outcome is much lower and where we need kind of robust risk stratification markers more urgently. Obviously, the hope is that with all these genetic abnormalities, we'll be able to identify the optimal treatment pathway, whether this is a combination of our current arsenal of therapeutic agents or whether it's new targeted therapies. But really understanding the genomic landscape really is the first step to determining whether or not patients need to receive targeted therapies or can be cured, as is currently the case for a large number of children with ALL with standard chemotherapy.